Good morning, and thank you, everyone, who were at the Healthcare Services Review Project Committee. And we will go ahead and get started. Start time is 8:30. Roll call. Annette, can you please take roll?
Yes. Supervisor Canepa?
Here.
Supervisor Dean? County Administrator Regallo?
Here.
Ms. Hopkins?
Here.
Mr. Brucker?
Here.
County Counsel Kiernan?
Here.
Ms. Macedo? Mr. Wiltkamp?
Here.
Ms. Valentine?
Here.
Mr. Castro?
Here.
Ms. Harlan? Ms. Ferrer?
Here.
Thank you. So on the agenda, the next, it's an action item. It's to approve the minutes from July 17th of 2024. The minutes should be in your packet. Does anybody have any, would like to discuss or any changes? If not, I will entertain a motion.
Move to approve.
Second.
All those in favor?
Aye. Aye.
Aye. Thank you. And we will move on to our information and discussion items. First, we had the Be Well update from Director Valentine.
Good morning, everyone. So this will be a brief Be Well update since we don't have a whole lot of new information since what was presented at the Board of Supervisors meeting in November. But the Be Well campus at large will enhance based off of treatment beds, 175 treatment beds within our county that will spread between inpatient units to lock units to outpatient supports, and a phase 2 that will increase our capacity for transitional and supportive transitional housing by 250 beds if we secure additional set of funds. At the November 14th Board of Supervisors meeting, our supervisors gave BHS and Healthcare Services at large the ability to apply for $137.5 million and Prop 1 Launch Ready grant funds in order to secure the project at large. The preliminary estimate costs for the phase 1 of the project is approximately $240 million. Healthcare Services and Behavioral Health has secured $65.5 million already, with a pending of 21 million out for grant award with Sutter Health Foundation. BHS is writing into their MHSA plan an additional $8 million that will be able to be spent in 26-27 if approved by the Board of Supervisors in our next MHSA plan. In addition to that, in working with the county administrative office at large, there's approximately $80 million in opiate settlement funds, capital outlay, that can be tapped into as a last resort if we do not secure the $137.5 million that is currently out for the Prop 1 grant. The grant awards should be released sometime in May in 2025. HealthNet and the Hilton Foundation have reached out to BHS and Healthcare Services at large, interested in potentially also funding the project. So we will be meeting with them to see what those grant options could be and what that would look like at large. In addition to that, Healthcare Services and BHS has been working diligently with our Community Development Department. We have submitted the specific plan and the project description. We are working through some minor edits, but we should have a project approved if everything goes as planned, no later than the end of February through our CDD department, and we've already started feasibility with travel and road studies and the CEQA process. So everything is moving as planned so far with the Be Well project.
Thank you. Are there any questions? Seeing none, thank you very much. We'll move on to the second information item, avoiding duplication of enhanced care management services, and again, by Director Valentine.
Thank you, CEO Regalo. So in the last 8 weeks or so of transitioning into the interim healthcare services director position, one of the things that I have been trying to do is see where there is duplication of efforts as well as gap in services. And one of the big things that has come abreast in this investigation is there are absolutely duplication of services occurring in enhanced care management and contracts that 3 different county projects have in terms of ECM services. Public health, whole person care, the hospital recently got approved to do ECM services, and the health clinics. At this point, at least in terms of public health, the project is not sustainable based off of the revenue coming in for ECM services. And so we are trying to secure additional funding that are based off of grants and so forth. However, there are duplication of services, and we probably should have a discussion on making sure that we are not duplicating Medi-Cal services chasing down which Medi-Cal beneficiary or member should fall in the right ECM team, and so forth. In terms of ECM at large, ECM is enhanced care management. There are 9 specific target population focus groups that DHCS allows. Those all include anything from homelessness, emergency care, mental health and substance abuse services, those in long-term institutions, those that are transitioning back to the community from nursing homes, or those that were involved in foster care or incarceration. They can be enrolled in the California Children's Services, or those that are pregnant and experiencing postpartum. The issue that we currently have is we are being kind of loosey-goosey in terms of the population. And even though each department has a very specific subset group that we are contracted with the health plans, they are typically the same clients that are hitting all the different departments. You are only allowed to bill for enhanced care management if you spend 2 hours of case management a month. You have to have a minimum of 2 hours a month for billable services. So I just want to make sure that we as an agency, we as a county are not duplicating efforts or potentially getting ourselves into trouble with Medi-Cal at large.
Thank you. Are there any questions?
So what percent are we talking? I mean, what's the deep dive getting you?
At this moment in time, Chairman Canepa, at this moment in time, we're looking at it's about a 5% member cost in terms of duplication. It's 5%. However, the impact at large is, at least public health, I can say that we are not breaking even by any means in terms of the revenue necessary for the ECM services to maintain the program.
And where their money, where did it go to run it?
So the services right now are being funded through grant dollars through 2027. The revenue of ECM will not offset when the grants no longer are in play. In terms of the hospital and the health clinics, I don't know how they're funding their positions, but it's definitely a conversation we should have in terms of how to make sure that this can be sustained. There are options of at least the public health team transitioning into behavioral health, since their target population is jail-based services and mental health and substance abuse. But what's happening now, at least for the public health team, is they either refer directly to the health clinics, and so there's this warm handoff that's happening, but neither team is actually hitting their 2 hours of billable time, because we're handing off before the 2 hour a month benefit happens. As for the hospital, they just recently started the program, so I don't have a good set of data yet on where there's that crossover.
Okay, and that was going to be my question, was the 2 hours. You said there's a 2 hour minimum in order to bill.
Correct.
And that is across the 9 different population
Correct.
groups? Okay, and then is that also across every county department, whether?
Yes, that is
clinics?
correct.
Okay, so, yes. we
Just
need
for,
to-
I'm sorry.
Go ahead, Rick.
Just for curiosity, what is the reimbursement for those 2 hours?
Not a lot, and I don't have the rates with me today. It really depends on what type of service. So there's ECM, and then there's also CSS, which is housing navigation, which reimburses at a higher level than ECM. And it's based off of a negotiation that you do with the health plan. I know that the public health rate is potentially not as high as the health clinics or the hospital, because this is not necessarily work that we've historically done.
I'm not sure that the 2 hours, the cost of the 2 hours doesn't exceed, I'm not sure the cost of the 2 hours doesn't exceed the reimbursement. That's the challenge with these programs, so.
Okay,
They're a loser to start. I mean, they're the right thing to do, but it's another, in a sense, without the grants, which we all have different opportunities for grants, and they tend to keep coming because they realize that. But standing on its own, these programs will not support themselves without a deficiency.
That is correct.
okay. And I appreciate, so right now you are gathering to maybe work on the duplication? Okay,
I would say that we should take this offline, sit down and talk through all of our services and the long-term sustainability potentials of this program. It definitely makes sense to provide this service when it's also provided in collaboration with other medical visit billable services and that type of thing. It makes up the gap, potentially, in revenue. So I think if we can look at where we direct these clients and patients to go, we can probably get a bigger bang for our buck as a system. And so I think if we take that offline, really map it out financially as a whole group, and recognizing that there is different populations that probably need to be served, and if we can really commit to, this agency will take care of this population, and then we stop any overlap, I think we can create something sustainable down the road.
I agree, and in January, it became a mandate that anyone coming out of the jail or juvenile hall is hooked to an ECM provider. So there is benefits to maintain a program in order to make sure that there is a streamlined transition from juvenile hall or the jail into other county programs, either mild to moderate services with the health clinics or with behavioral health. But we definitely need to make sure there is a streamline so that we are not having staff do duplicated services and really align where teams should be and the financial impacts.
So who gets the best reimbursement rate?
It sounded like the hospital.
I
I thought,
I believe it's the health clinics.
I believe it's the clinics, just guessing.
right.
So that would be the idea, to send it to where you get most bang for your buck. I mean, is there that much difference?
Yes.
Yeah, I'm not sure of the details, but I agree with 100%. If there's a program that's questioned, we can say the same example, for example, exists in public health lab. We send tests to public health lab at a very high rate that we can do in our own lab for next to nothing. But the opportunity or the challenge for public health is that without that revenue, they become operationally in the red. So we're paying inflated prices to make another county department operate in the black, which is maybe something that could be looked at as to say, what's the best for the county? What's the best bang for our buck overall in everything we do from a healthcare perspective? So if the opportunity is best in the clinics for the ECMs, then we should focus the whole program to go to that entity, right? From a business perspective. Same holds true for public health. If the best opportunity is to do the test where it's the cheapest, maybe we should evaluate to say, well, we could stomach the loss here because we understand that there's overall we're revenue positive.
And I would just add that it's just not as easy as saying we're gonna send everybody here. We have to recognize patients have the right to choose where they receive care. And so that does create some potential gaps that we'll need to evaluate if patients say, I don't wanna go there, or that is not my preferred provider. It could then jeopardize the financial stability long-term of the program. So we'll have to talk through the weeds of that potential as well, and figure out how we could best approach it.
To make it even more convoluted, you cannot do a service for a Medi-Cal beneficiary that is less than any other commercial insurance. So we also have to make sure that we are mindful of if someone's coming out of the jail or is a homeless individual that we are providing these services to but don't have Medi-Cal, that we are securing the same level of service so that we are not in CMS violation. So it's definitely a onion of sorts that we have to work through, but I'm hopeful that collectively we can streamline the process to save the county money and efficiency for those that we're providing these services.
Thank you. Any further discussion? No. Thank you for that. Moving on, we will go to specialty clinics. Move update by CEO Castro.
So good morning, everyone. I don't know if I said that to begin with. Good morning, everyone. Thanks. The clinics suffered a little bit of a drawback in that we decided it was better to do the floor before we moved all the pieces in. So the flooring is the holdup right now. We have the bid for the floor coming in. We believe the clinics will be now operational. We hope beginning of February. Looks like the beginning of March. So we hope that we'll be out of that clinic space. We also evaluated some space that I know the VA wants for, that we could put a call center. We have a spot in the towers that we believe is big enough and could be easily converted to a call center for all of the entities of the county.
Rick, can you share with the team what's moving into the new space?
So mostly what's moving into the new space is the surgical specialty clinics, all of the GI, let me think if I can remember these all, orthopedics, general surgery, you know, obviously trauma operates out of the hospital, not in the clinics, so all of the surgical services are moving to the VA clinic. There will be a procedural room in the VA clinic as well that will be doing limb salvage, a number of outpatient procedures, and potentially even some GI. So more of an outpatient opportunity for us to provide better service, because our waiver for the towers, which I knew was coming, has now officially been denied. So the hospital sits at 152 beds, understanding that 25 of them are ICN, which is NICU, and another 25 are MGU, which is the prison. Both of those entities run at about 40%. So the actual adult beds that we have are 120. Over the last month, our typical average daily census has been about 180, at one point up to 194. We were housing those patients in the towers based on the least acuity. The least acuity patients would go to the towers because it's not ideal. There's not bathrooms in the room. It's a little bit of a, as I call it, cuckoo's nest atmosphere in the towers. But that's been denied, so we've have to go back into the hospital now and find a place for 42 patients. So hallways, waiting rooms, everything has been, we're going to continue to be challenged with space from a capacity perspective, and from a long-term perspective, again, looking at Joe's running 400 plus with a bed capacity of 380, looking at the hospital running at 180 with a capacity of really 120. Looking at the challenges from Dameron's perspective in retrofitting, and they're having a new buyer. I mean, those are the only available beds, but the building is not retrofitted, so that's a huge cost coming our way. The county's going to struggle over the next decade with beds, and I think it's something that we have to look at overall, and we'll be presenting that at a different date.
So the retrofit is worth it? I mean, so you have 5 years, it's 2030 when that's what the gentleman from Denver
The great
said,
part of the
that
hospital.
there's 5 years before you have to.
The great part of the hospital is all of the new building is obviously coded, up to code for retrofitting. Doesn't need to be. The challenge with Dameron is, I believe, a 3-story building. I've never been inside of it. It is not. And single level buildings, obviously, from a retrofit perspective, are a much less cost. When you're looking at the potential to retrofit a building like Dameron, I can't imagine that it wouldn't be anything less than $100 million. That's complete speculation from an entity that's had some financial challenges. I'm not bringing this up to despair anybody. I'm saying from the community perspective, bed challenge is going to be significant. Now, Joe's has a new tower that I believe will add a number of beds, but under the best case scenario, you're looking at 7 to 8 years. So I think we have to get on track to say, what should we do in the future as far as bed goes? We have the only building on our campus that is not retrofitted from a patient perspective of all things is the cafeteria. And it surprised me because it's a single level building, so you'd think retrofitting would not be a major issue, but it is. So that building has to be replaced. That cost is about $30 million. And I think it would be better to look at an alternative where, instead of replacing a single building in the middle of the campus, to use the $30 million as the bottom floor of a tower that was looked at, I guess, about 10 years ago. So very expensive project, probably around 150 million by the time it's said and done. But as opposed to spending 30 million on a cafeteria retrofit and then, 3 years later, starting a expansion that, would cost another, be cost on top of cost as opposed to all in one bucket.
So the property you were talking about is the old VA clinic that you're in now?
No, I'm talking about the hospital overall.
No, but where'd you move those?
The VA clinic, so the clinics
old-
outside, the specialty clinics right outside the hospital, so when you come into that main entrance, those are the clinics there. Those are the ones that we're moving to the VA. The FQ will then take some of the space that is vacated from us going to the VA clinics to expand their clinics. That's kind of there's not a whole lot of cost associated with that.
And how many, there was the exam room, so you took all that over?
We took all that over, yes. Or we will be taking all that over, right.
Okay. Thank you.
Are there any other questions or further discussion?
Can I just make one clarity?
Yes.
The call center that is moving from E2D2 is actually the clinic's call center, not VSO's call center. They just happen to be co-located with E2D2, VSO, and the call center.
Thank you.
That's the space the VA wants though, correct?
Yes, that is correct.
Okay. Thank you. Okay, so there are no more discussion items. We'll move on to public comment. Annette, can you tell us if there's any public comment?
There's no public comment.
Thank you. And that brings us, we'll move on to our committee comments. Are there any committee members that would like to share any comments? I do have a couple of updates that Brandy was she was nice to write down some notes for me, so if you'd like, I can start and maybe go from there. Okay, and this is really from what our office has been involved with each of these. First, the healthcare services, hospital, and clinics collaboration efforts. The county administrator's office, we continue to work with all healthcare services departments to streamline services, increase quality, and enhance internal collaboration. Healthcare services and the clinics are working on the Lodi Access Center and coordinated behavioral health services. And the hospital and the clinics have reestablished reoccurring management and quality meetings. Before I move on to a couple of other updates, would anybody like to add? Any? No?
I would just say it's a real pleasure to work with Stacy. I think that, for the first time, there's some optimism that we have collaboration in the right direction. So welcome and thank you.
Thank you.
Thank you, Rick. I'd just like to take a minute to say, I think I'm in week 6 here of my new role, and it has been a bit of a hurdle trying to understand the layout of the county, the clinics, how we work together, hand things off, and I do see just in that short amount of time a lot of opportunity for us to really improve services to the community at large. For sure, and so I'm really looking forward to working with these guys on some of that and really stepping forward, I think, and trying to be more accessible to the folks in our community. I think that has been a struggle, and so we are aware and working on it, and we'll have things to share with you shortly on the efforts and timelines and that type of thing, so we'll circle back in the future. Thank you.
Thank you.
CEO
Go
Regalo,
ahead.
may
I have a
I-
question on financials. Are we getting a financial update?
Yes, so those are
We
going to
haven't had a
be brought, excuse me, Chair. Those will be brought to this group twice a year, and so that will be at the next meeting on April 16th. We'll have the financials.
Okay.
Okay.
CA Regalo, one of the things I'd like to add about the Lodi partnership, the clinics and BHS actually have started conversations about the Sobering Center that would be hopefully stationed in that proposed project. We are going to actually do tours of sobering centers that are jointly done to see what it would look like to make sure that we are efficient in terms of the sobering centers. We've also asked EMS to participate to see if it's possible to turn that sobering center into an alternative destination so that we are not impacting our hospital beds, both in Lodi and here in the French Camp area, to make sure that we can divert those that need sobering to that location in Lodi. So we are in the exploratory process of that now.
Thank you. Okay, moving on to the co-applicant agreement, we wanted to provide you with the status update. This has been reviewed by County Council and is near final draft. The main points are proposed structural and clarifying language regarding the county's role as the applicant and board control over supplemental funding and county policies and procedures. Our next steps is for our county administrative team to conduct board briefings and then brief the clinic's chair and the leadership team, and final changes need approval by the clinic's board and by the Board of Supervisors. And once approved, the MOU will be negotiated with the affected departments. Any questions on that? Nope. Thank you. And then an update on the management services agreement. So our current MSA expires on June 30th of 2025. The recommendation is to extend in the current phase, no structural changes. The county administrator's office, the hospital, county council, and Common Spirit are working on updates to the MSA. And Common Spirit has requested a flexibility in county rules to allow the hospital to function similar to private hospitals. So the procurement, contracting, and personnel rules. Then the creation of an oversight board for credentialing, licensing, and quality metrics review. The county administrator's office and county council currently researching this option. And the target presentation to the Board of Supervisors is in March of 2025. And then just, I'm sure you all know, but just to note, Don Wiley has retired, and the county team is working with BJ Predum, the service area president, and CEO Castro. Any questions? Yes.
Just to add on to that, the new CEO of St. Joe's has been, was advertised today. So the new guy came from Tenet. We don't know much about him, but
He came from Tenet?
came from Tenet. Correct.
Thank you. That's all I have. Did anybody else want to report anything on committee assignments?
I'd like to report the update on the medical school.
Yes, please.
So the medical school, we're actually meeting the potential dean today. That has to happen for all of the bureaucracy, in a sense, why the building is taking place. They got the original bid for the building, for building out their essential school, the classroom part of the school. It was a little surprising to them. I think inflation has been a shock to everybody. So again, as I said all along for the medical school, the challenge for the medical school is going to be to raise the funds. That's their challenge, not necessarily ours. We're doing as much as we can by facilitating meetings with especially potential physician donors that might be there, but that's, not our responsibility. That's theirs. They're comfortable that they're going to reach those goals. So we continue to move forward in that respect, and we're pretty excited to actually meet the dean, and we'll do that as soon as this meeting's over today. So, any questions?
No, that's exciting. Thank you.
Also, a meeting with the Stanislaus State president, the opportunity to possibly teach more classes for nursing if they, had more labs. So I thought that was important. I guess she came from an area where they started a school to train like 800 nurses for it, and then they got commitments, so they would train them and then got like 3-year commitments to stay in the area. So made sense to me, but I don't know how we get the partners to help them.
So we met via phone this
Oh,
week.
did you? Oh,
We
thank you.
We don't want to waste any time on that.
Oh, okay.
And so we're meeting in person, I believe, next week. And, the nursing part's exciting, but probably equally as exciting, because we tend to ignore the rest of the professions. OT PT speech would be really fabulous if they provided that, both from an opportunity for our local community to go after those professions, but the need as well. So they're looking at those other places where the volume is not same as the nursing, but the challenges of the shortage remain the same. CT techs, let me think who else, all of X-ray, as I said, OT-PT speech. So those are very helpful as well, and she's very excited about what her opportunities are, so we're gonna jump right on board with that as quickly as we can.
Yeah, because so Sarah set it up from the Community Health Leadership Foundation, and then so, thank you for engaging. She told me that, so I said, here you go.
Good.
The more people we get trained, and I didn't know Delta College obviously trains a different nurse, so if there's a way to grow them locally, I think we should try to figure out how to do it, so thank you.
I don't think there's any such thing as too many nurses. I don't think that's ever gonna be a problem.
To add to that discussion, so behavioral health already has an agreement with Toro University, which is a partnership with Common Spirit for us to do a fellowship program for psychiatrists starting in 25-26. They reached out right before the Christmas holiday wanting to also do psychiatric nurse practitioners, which would be incredibly helpful with our partnership with Common Spirit at the hospital and allowing us to have a rotation within behavioral health in the hospital for psychiatric nurses, which could eventually, even if passing background checks, allow for additional support at correctional health. That agreement would require them to stay with county employment within either one of the three health service divisions for 3 years after the fellowship.
And I'd just like to add to that, in my past life, the world changed in regards to psychiatric care when we had the ability to use psychiatric nurse practitioners. It's a game changer, because they're, as opposed to being episodic, waiting for the psychiatrist to come in, they're part of the team that works, a significant shift to make, to eliminate that constant bed being taken up, not because the patient hasn't been seen. So that's great news, because they're probably better suited for a hospital role than psychiatrists specifically.
We'd be happy to use them on the clinic side as well. They do help support and uplift our family medicine providers in providing services. So it would be a very welcome addition.
Thank you. Okay, so if there are no further committee comments? No? There are no closed session items scheduled for today. And so with that, we can adjourn at 9:03. Thank you.
I think that's a record.
Is it? No.
Thank you, everyone.